everyone. We will be starting the first episode of LabMed Tell from Head to Tail. And when I have started this, I thought that we'll start with something, such a topic which can help an undergraduate student, a postgraduate student, even a lab technologist also. Because the markers, I'm talking about the cardiac markers. So since cardiac markers are vast and huge, so we have decided that we'll start with it in two parts. First, on the basic markers, which is a day-to-day requirement, everybody's knowledge, and the second one is an advanced markers, which are mostly to be for the point of care testing as well as the advanced cardiac markers coming in the upcoming days. So starting this first as the part one of the cardiac marker. Straightway go to the cardiac marker. So what I was talking about, an ideal cardiac marker, what we talk about, the cardiac markers previously used to know that the markers, the parameters which depicts the cardiac injury are called the cardiac markers. So nowadays, if you talk about a cardiac marker, the ideal cardiac marker which should be that should have a high sensitivity. That means that should be present in a high concentration in the myocardium, and that can be released immediately after a myocardial injury, even after a small myocardial injury. So that can be the rapid release is better for early diagnosis, and those who have a long half-life, it is important and it is very helpful for late diagnosis. So if you consider the second one is the high specificity, which is very much important, because in previous days majority cardiac markers have got so many origins of skeletal muscle in brain and all other areas. So you cannot actually define that raised parameter means only cardiac injury, but nowadays the high specificity one making it more important and more valuable, because this should be present only in myocardial and absent in all non-myocardial tissue, and should be non-detectable in blood of non-disease subjects. That gives just a high specificity of the marker. Analytical parameters there that should be measurable by a cost-effective manner, simple to perform, and should have a rapid turnaround time to call it an ideal marker. And last but not the least, the clinical characteristics that it have the ability to influence the therapy and ability to improve the patient outcome. That means this parameter should be able to diagnose, prognose, and everything of a cardiac injury. So that should make it an ideal cardiac marker. Now this is what I can show you that why the cardiac markers are coming in the blood in different times, and they are important for different reasons. So now look at the cardiac muscle cell. How does it look? Here is in the nucleus, you may get some of the CKMBs, and in the mitochondria, you may get some CKMBs over there. But mostly the myoglobins are present in cytoplasm, and the troponins are in the contractile apparatus. So what happens immediately after injury? It is the cytoplasmic markers which comes out first, and then the mitochondria and other tissue organelles, which actually cell organelles, which are destroyed, and gradually they get released in the blood after the injury. And that is why myoglobin is the first to appear in blood. So earliest cardiac marker, followed by others, and only after the total cell degradation, the cell organelles are degraded, and gradually the markers come in the blood. So what happens? These are the markers which is mainly present in the cardiac muscle cell. When cardiac muscle cell injures, it comes to the blood and becomes visible in the serum. So that gives the diagnostic importance of it, and that is why the different things come up in a different time period. Now the biochemical markers that previously having a traditional thing we used to call a cardiac marker, CK, CKMB, LDH, and SGOT. And now it is recent we use others, particularly CKMB mass. And the most important thing is that who the champions of the time now is the cardiac troponins. Cardiac troponins T and I and myoglobins. And in future there are some other markers coming up, which is ischemic modified albumin, fatty acid binding protein. These two are actually mainly in the market nowadays, which may have some bright future in diagnostic as a diagnostic marker. High sensitive CRP is most of a prognostic marker than a diagnostic marker. So all are the markers coming up in the market coming up later on. Now, if we talk about that, cardiac troponin I, this is the champion now. Now, every cardiac diagnosis now on the basis of these two cardiac things, one cardiac troponin T and cardiac troponin I. Now, previously also, troponin I was there. The troponin I was never considered as a very ideal marker. But nowadays, this one which is identified as the cardiac troponin I, which is human cardiac troponin I, which has got an amino acid residue on its N terminal, which is absent. This amino acid is absent in skeletal form, and that made it too much specific for a cardiac muscle, and that is why the diagnostic importance has come up. So after the cardiac troponin I detection level, we started. It starts 2 to 8 hours after cardiac injury and remains about 7 to 10 days. So it's a long-standing one. It has got a secondary peak in the later on. So it is most important one for definitive diagnosing within the golden period time, as well as if somebody, particularly in Indian condition, when majority time you actually miss the bus, you don't reach the medical unit when you have a heart attack. Mostly majority people come very late. So those cases, actually, this is one of the most important one to have some late diagnosis as well. So in the countries like India, you cannot ignore that also. So cardiac troponin T, that is also almost having the similar nature of cardiac troponin I, but it is actually remains a bit more in so far timing is concerned. But so far diagnostic importance is concerned, it also having more or less similar kind of importance of cardiac troponin I. And trop T, the cardiac trop T for point of care testing, it is one of the most likely choice of cardiac enzymes. Now, if you look at this, this is the thing where you can find that the initial time period, this is one, this purple one is a cardiac troponin I, and this red one is a cardiac troponin T. They have the capacity to rise very early up to the 4 hours, within 4 hours time period, and remain in blood about 4 to 12 hours, then declines and remains high above range for quite a long time period, so that this helps in early diagnosis, definite diagnosis, as well as also for late diagnosis. These are other markers like AST, which rises also at the similar time of cardiac troponin, but peaks at about 24 to 36 and gradually declines down. LDH is the low one to rise, about 12 hours it takes time to rise and stays for long. So LDH is another enzyme which actually helps in a late diagnosis of MI. Although nowadays we know that for late diagnosis of MI, we don't have any significance when the golden period has already passed by. So we always try to catch the earlier one. Okay. So always try to catch the earlier one. And the myoglobins not present in this graph, but they are the fastest to appear. They start appearing within 1 hour. So therefore, if there is a definite sign and symptoms of myocardial injury or MI, when the patient is clinically showing MI, then if this myoglobin is raised, then definitely you can go for a diagnosis of MI. If ECG suggests your findings, you can go for definite treatment. So the time period, which is very important for myoglobin, but myoglobin has got a definite disadvantage, has got no specificity, and even in skeletal muscle injury also, you may have a high myoglobin. So talking about specificity, sensitivity, and timing, in every sense, TROP-I is the best one. Now you can have a look on this, all of them. CKMB useful in diagnosis of infarct and reinfarct.
AST does not have a specificity because it is also a liver enzyme marker, also skeletal and muscle enzyme marker. But the TROP-I has got the complete cardiac specificity, and that is why it's considered to be the best marker. Then we come to some other cardiac diagnosis, that the brain natriuretic peptide. So it actually identified from peak brain, so that is why it is called brain natriuretic peptide. That is actually it is mainly atrial natriuretic peptide, because this kind of proteins, whenever the cardiac volume overload goes, the atrium stretches. With the stretching of the atrium, it triggers a positive stimulus to the heart, and therefore immediately after the positive stimulus is released, the brain natriuretic peptide that releases, and therefore the condition and that ABNP rises. So if you get this, so sometimes you may get confused with what does it mean by NT-proBNP? So this NT-proBNP, if you consider with that the proBNP is a 108 amino acid residue. So which when it gets activated, that it cleaves on the 76th position, from 77 to 108 this part, and from 1 to 76 this cleaved in two parts. So therefore the proBNP section is actually the NT-proBNP, the N-terminal proBNP, that is the 76 amino acid residue one. So what happens, BNP has got a very low half-life. It has got an extremely low half-life, so it's very difficult to diagnose or to analyze this parameter in our lab setup. So proBNP is actually, or NT-proBNP is actually the equivalent portion of BNP. So one BNP is produced, one NT-proBNP is produced, just like insulin and C-peptide. So if you diagnose, if you analyze, or if you quantitate proBNP, that means the equal volume of BNP is also produced. The advantage of this NT-proBNP is the stability is high. It has got a half-life of 120 hours. So you get enough time to diagnose it or analyze it in the lab without getting degraded, which the BNP does not have. BNP degrades early. So therefore a proper quantitation in lab is been very difficult. Now, markers of myocardial infarction and heart failure. So now overall, if you consider it, we consider this cardiac markers into three varieties. So one, which is use of prognosis of MI. That means these are cardiac prognostic markers, like all what I have said, HSCRP, myeloperoxidase, high sensitive troponin I, high sensitive troponin T, the fatty acid binding proteins and fragments, all they are mainly showing the chances of developing MI or prognosis of the patient's heart condition, whether it is possible that the patient is likely to go for an MI or not. And so that is why they are called prognostic marker. Now the markers which definitely says there is a cardiac injury has happened and there is a possibility of MI are called MI diagnostic markers. These are cardiac troponin I, troponin T, fatty acid binding protein, myoglobin, CKMB, LDH, and AST. They are the diagnostic marker. Now, apart from diagnostic marker, if I consider the cardiac health is also jeopardized when there is a cardiac failure. Heart failure is a condition where myocardial injury may or may not happen, but cardiac function deteriorates. In those conditions, the missed marker is proBNP, NT-proBNP, and BNP, all the natriuretic peptide family. So this is all about heart in a nutshell, and I hope this cardiac markers are made easy a bit for you to understand, although with such a quick period of time, it is not possible to actually undergo entire thing of cardiac marker, but I can at least give a brief of idea about what are the cardiac markers, what do you intend to analyze, and what actually they signify.
Thank you everyone for this patient listening. And I think I could give you some idea about the cardiac markers, its requirements, and why a specific cardiac marker is required for a diagnosis and the timeliness of diagnosis. So this ends the part one, and we'll go for part two very soon in the next week. And keep on liking and subscribing our channel so that we get more enthusiasm to get you more and more topics like this. Thank you.